Dear Chairman, dear colleagues, this is Christian Napp from Hannover Medical School. Thank you for inviting me to talk about hemodynamic monitoring during mechanical circulatory support in cardiogenic shock. These are my disclosures. In cardiogenic shock, we are in a rather unique situation as compared to septic shock, for example, where we need to protect the acutely diseased heart as well as all other end organs at the same time, which has lots of implications for medical therapy, but also for mechanical circulatory support strategies and monitoring. This is nicely reflected by a rather old study from 1988 in sheep. So in a large animal models, the authors had a control group on the left and an acute myocardial infarction model on the right, where the LAD was ligated. And you can immediately see that depending on the ECMO flow in the left graph, the systolic wall stress and diastolic pressure and also volumes are decreasing depending on ECMO flow. In contrast to the acutely diseased heart, which differently responds to ECMO flow, so end-diastolic pressure and systolic wall stress increase with higher ECMO flows. That tells us that the acutely diseased heart completely differently responds to mechanical circulatory support strategies, which needs to be taken into account when applying this therapy to patients with cardiogenic shock from, for example, acute myocardial infarction or acute on chronic decompensated heart failure. A major complication of VA ECMO support, for example, is left ventricular stasis and thrombosis, which needs to be investigated and monitored. So by applying a sophisticated hemodynamic monitoring, we are able to early detect reduced flow through the pulmonary arterial bed. So use of hemodynamic monitoring is absolutely essential, in addition to echo, to monitor for changes in the body introduced by mechanical circulatory support. Of course, you need to monitor lots of different things, metabolics, you need to do echo, the coagulation system, and so on. We do, for example, echo every 8 hours in patients. And after moving the patient to be sure where are the cannulas, for example, if you use an impeller pump, is the position correct, how are the chambers behaving, and so on. But it's essential in the end to apply sophisticated hemodynamic monitoring in those patients to measure the pressures and flows in those patients. This is nicely reflected by this manuscript from 2015 from Dan Berkoff and colleagues, where the authors demonstrated that depending on the flow in this example by an impeller device, ventricular vascular uncoupling occurs. So the aortic pulse wave is dampened. That tells us that pulse contour analysis, for example, by the PICOS system, is not reliable in those complex patients to estimate hemodynamic changes introduced by MCS and the underlying condition. So we recommend to perform a complete baseline, a check-in on the ICU, maybe already in the cath lab, and this, of course, comprises an echo and full labs and so on. But we put lots of emphasis on hemodynamics, invasive hemodynamics, by a PA catheter. With a catheter, you can measure directly pressures and flows. For example, the central venous pressure, the mean arterial pressure is measured by arterial lines. With this one you can in addition measure the mean pulmonary arterial pressure, the pulmonary capillary wedge pressure, and also cardiac output or cardiac index. But you need to take into account that patients on VA ECMO, depending on the venous cannula position, thermodilution might not be as reliable as compared to patients, for example, with an impeller pump or other devices not introducing an extracorporeal shunt in those patients. And you can calculate several different parameters from those directly measured values. For example, the pulmonary arterial pulsatility index, cardiac power output, and pulmonary and systemic vascular resistance, maybe also indexes. And those are very important values for monitoring and guiding therapy in your patient. The CPO is already a traditional marker and calculated by mean arterial pressure times cardiac output divided by 451. And already 16 years back in the shock trial, the authors demonstrated that reduction in cardiac power output is directly associated with an increase in in-hospital mortality. And you can further sharpen this image by adding the number of used inotropes and the levels, systemic lactate levels in your patients. And here in nice works from Detroit, the National Cardiogenic Shock Initiative, the authors demonstrated that in patients on low cardiac power output, high use of inotropes, different inotropes, and high lactate levels, survival is strongly decreased in those patients with acute myocardial infarction-related cardiogenic shock. Another important parameter is the pulmonary capillary wedge pressure and the central venous pressure. So the pressures measured indicating left atrial and right atrial pressures as a surrogate of preload for the left and the right ventricle, which is modifiable by mechanical circulatory support settings, by volume management, and also by different drugs. Another important parameter is the PAPI, so pulmonary arterial pulsatility index. This is easily calculated by dividing the pulse pressure, so systolic pulmonary arterial pressure minus the diastolic pressure, divided by the central venous pressure. And for example, in patients with low pulmonary arterial pulsatility and high central venous pressure, this indicates severe right ventricular failure, either acute or chronic, in those patients, which then helps you for decision making in MCS in those patients. So even if treatment goals, of course, should be individualized, and this depends on the device used, on the patient itself, comorbidities, and the underlying condition, of course, you can tell some rough rules for guiding therapy in those patients, depending on measurements of the pulmonary artery catheter. For example, you should maintain a mean arterial pressure of 70 or above, and you should control the pulmonary capillary wedge pressure, which should be below 20 or even lower. You should maintain the central venous pressure between 10 and 15 millimeters mercury, so not too low, but of course not too high, and keep the PAPI and the CPO above 2 and 0.8 respectively. Of course, depending on the disease state and the MCS device used. This is also associated with outcomes in those patients, and it's not just measuring numbers. Here from a study again from Detroit from 2013 in patients with acute myocardial infarction, cardiogenic shock, where the Impeller 2.5 device was used, and use of this device was immediately associated with an increase in mean arterial pressure, lowering of the pulmonary capillary wedge pressure from 32 to 19 millimeters mercury, and an increase in cardiac power output, which was then immediately associated with a strongly increased survival in those patients. And this was confirmed in another analysis from the National Cardiogenic Shock Initiative, where the authors analyzed more than 15,000 patients with AMI-related cardiogenic shock supported with an impeller, and use of the PA catheter was in this context independently associated with increased survival in those patients. But it's not only important for adjusting your device settings, for example, or medical therapy, it's also important for the whole strategy. For example, in patients with acute myocardial infarction and impeller CP support, do I need an additional VA ECMO? So do I need to upgrade to ECMELA? Do I need a stronger impeller pump? Do I need right ventricular support? And of course, measurements with a pulmonary artery catheter can help you for decision-making in this setting. So a high capillary wedge pressure on support, a high central venous pressure, and a low pulmonary arterial pulsatility indicating RV failure on the impeller, for example, a low PAPI, a low CPO. Those are all indicators which are not self-standing, but help you to make wise decisions for patients on support. So in summary, in patients with cardiogenic shock, pulmonary artery catheters provide direct measurements of pressures, are especially advantageous for identifying RV failure, are independent from the arterial pulse rate, which is a strong advantage compared to other hemodynamic monitoring systems, reflect hemodynamics across the whole spectrum of shock, so from pre-shock stage A, for example, until D and E. Invasive hemodynamics using PA catheters essentially guide clinical management before MCS, during, and early after MCS, so in this very vulnerable phase of weaning and recovery. Thank you.